Okay, let's dive right into our syllabus. We're going to cover vaginal bleeding and abortions, surgery in pregnant patients, gynecologic surgical anatomy, vulvar and cervical carcinomas, and finally, endometrial and ovarian cancers. We've got a lot of ground to cover, so let's get started. Section 1, Vaginal Bleeding and Abortions. We're kicking things off with obstetric etiologies of vaginal bleeding. You'll see this all the time. It actually happens in about 40% of all pregnancies, and roughly half of those cases ultimately result in spontaneous abortions. You really need to lock in these strict diagnostic criteria because they're the absolute key to your clinical management. The major differentiating factor here, whether the cervix is open or closed. It's that simple. A threatened or missed abortion will present with a closed cervix. Specifically, a threatened abortion has no expulsion of the products of conception, while a missed abortion is a non-viable gestation under 20 weeks that's just been retained. On the flip side, an incomplete or inevitable abortion features an open cervix. With an incomplete abortion, you're going to see a partial passage of those products of conception. So, what's your absolute first step in the triage pathway for abnormal vaginal bleeding? You've got to check a urine beta-HCG. This brilliantly and immediately branches your differential diagnosis right down the middle into obstetric versus non-obstetric etiologies. If it's positive, you're looking at pregnancy complications, like an ectopic pregnancy or a spontaneous abortion. But if it comes back negative, you instantly shift gears to the Palm-Cohen criteria to hunt for non-pregnant uterine bleeding, structural issues, or coagulopathies. Moving right along to Section 2, Surgery in Pregnant Patients. Now, surgical intervention during pregnancy is all about managing this really delicate balance between maternal and fetal safety. The absolute most crucial point to remember here is that pregnancy is literally never an absolute contraindication to indicated or emergent surgery. If the surgery isn't an emergency, the second trimester is your safest window. This helps you avoid first trimester spontaneous abortions and third trimester preterm labor. As for physiology, you've got to manage it proactively. Administer non-particulate antacids because of the increased aspiration risk from elevated progesterone. And always, always implement left lateral positioning in the third trimester. This prevents that dangerous inferior vena cava compression. Finally, if the fetus is between 23 and 34 weeks, give antenatal steroids to accelerate fetal lung maturity. Just keep that traditional viability threshold in your head, 24 weeks or 500 grams. Now, what if you're doing laparoscopy? Your surgical technique definitely has to adapt. For your initial trocar placement, it's highly recommended to use an open Hassan technique, or alternatively, a left upper quadrant entry. Whatever you do, strictly avoid the varus needle. You do not want to risk a catastrophic injury to that enlarging uterus. Oh, and a carbon dioxide pneumoperitoneum up to 15 millimeters of mercury, that's generally considered safe. Section 3, Gynecologic Surgical Anatomy. Look, all these procedures rely entirely on a rock-solid structural foundation. You simply cannot safely operate in the pelvis without completely mastering this anatomy. Let's trace the primary blood supply. The uterine and cervical flow originates right from the uterine branch of the hypogastric artery. Notice specifically how the uterine artery passes directly over the ureter, right within the cardinal ligament. We call this the water under the bridge relationship. It's an absolutely critical concept you need to visualize when you're trying to control unchecked uterine hemorrhage via hypogastric or uterine artery ligation. Navigating the pelvis is like solving a high-stakes puzzle, and it requires understanding 5 specific avascular planes: the prevesical, vesicovaginal, paravesical, pararectal, and rectovaginal spaces. Developing these exact spaces is absolutely essential. Why? Because it allows you to safely isolate structures, spot the ureter, and completely avoid devastating adjacent organ injuries during major surgeries, like a hysterectomy. Next up is Section 4. Vulvar and cervical carcinomas. Shifting gears into oncology, we've got to rapidly review the staging and management paradigms for lower genital tract malignancies. Let's look at vulvar carcinoma first, which, by the way, is highly associated with HPV. This disease is staged both clinically and surgically. The gold standard of care here is a radical excision with at least 1 centimeter margins, and you have to carry that deep excision all the way down to the inferior fascia of the urogenital diaphragm. Now, how you manage the lymph nodes is dictated heavily by 2 things: the size of the lesion and its distance from the midline. If the lesion is greater than 2 centimeters from the midline, you're doing an ipsilateral lymphadenectomy. But if it's less than 2 centimeters, that requires bilateral evaluation for sure. And this anatomy directly dictates our surgical approach. Notice how the lymphatic drainage of the vulva pathways straight into the superficial and deep nodes of the femoral triangle. Metastases follows these exact pathways strictly. That makes inguinofemoral lymph node assessment a massive cornerstone when it comes to vulvar cancer staging and predicting survival. All right, let's move over to cervical cancer. Unlike vulvar cancer, cervical cancer is strictly clinically staged. This relies on standard worldwide practices, which means a physical pelvic exam, an X-ray, an intravenous pyelogram, and endoscopy. While we definitely use PET and MRI scans to guide treatment in the US, they actually don't change the official clinical stage. Early stages are managed surgically. Think a LEEP, cone biopsy, or radical hysterectomy. However, locally advanced cases, meaning stage 2B and beyond, are treated strictly with primary chemoradiation, specifically using sensitizing cisplatin. Now, picture this. You're down in the emergency department, and you encounter a massive hemorrhage from a necrotic, bulky cervical tumor. Listen to me very closely. Do not attempt resection. Your absolute immediate first step is to apply a really tight vaginal packing using acetone-soaked gauze. Acetone is actually highly effective for vessel sclerosis in these necrotic tumors. Get a Foley catheter in there and immediately consult interventional radiology in case embolization is needed to stop the bleeding. Bringing us to our last stop, Section 5, endometrial and ovarian cancers. We're heading up to evaluate malignancies of the upper genital tract. So endometrial carcinoma is actually the most common gynecologic cancer in the US, and its pathology is fundamentally split down two very distinct pathways. Type 1 cancers are your most common ones. They're estrogen-linked, usually have an endometrioid histology, and are generally lower grade. Type 2 variants, on the other hand, they are estrogen-independent, high-grade, and super aggressive. We're talking clear cell, serous, or poorly differentiated adenocarcinomas, and unfortunately, they carry a much poorer prognosis. Because the standard of care requires full surgical staging, which includes a total abdominal hysterectomy and bilateral salpingo-oophorectomy, you really have to understand the lymphatic spread. Endometrial carcinoma spreads in a very predictable way, right through the pelvic nodes and up into the para-aortic nodes. So your surgical staging is often going to require a bilateral pelvic and para-aortic lymphadenectomy, just to accurately assess how far the disease has spread. Once you're post-op, your treatment logic is instantly dictated by the depth of myometrial invasion and the specific tumor type. For instance, if you have a stage 1A tumor with less than 50% myometrial invasion, observation alone is often enough for a type 1 cancer. But the second that invasion deepens, or if you identify a nasty type 2 histology, the algorithm escalates rapidly. You're immediately looking at vaginal brachytherapy, pelvic radiation, or even systemic platinum and taxane chemotherapy. Finally, we absolutely have to touch on ovarian carcinoma. While endometrial might be the most common, ovarian is, without a doubt, the deadliest of the gynecologic cancers. You've got to keep a really high clinical suspicion for this, especially in your older patients. Key risk factors to watch out for include BRCA1 or BRCA2 mutations and a history of uninterrupted ovulation. You'll spot that last one in clinical histories featuring no lipidity, early menarche, or late menopause. All right, let's wrap this up by testing your integration of these facts with a quick clinical vignette. Based on everything we just covered, if a 62-year-old postmenopausal woman walks into your clinic with new-onset abnormal vaginal bleeding, what single diagnostic procedure must you perform immediately to rule out the most common gynecologic malignancy? The answer? An endometrial biopsy. This simple, rapid office procedure is your absolute frontline defense. Look, remember these algorithms, visualize those anatomical planes we discussed, and keep your staging principles sharp. They are going to dictate your success in the operating room. But as you master these traditional surgical foundations, I want to leave you with one final thought. How will emerging targeted biological therapies and robotics reshape these rigid anatomical boundaries over the next decade? Thanks for joining us for this explainer.